Welcome to the Committee on Health and Human Services this afternoon. Secretary, will you please call roll?
Assembly members Dahlia, Edgeworth, Gonzalez, Goulding, Gray, Hafen, Hibbets, Hunt, Jackson, Koenig, Nadeem, Wynn, Orentlicker, Chair Brown-May.
And I am here. Thank you. Would you please mark Assemblymember Gray present when he arrives? I feel like we're going to keep saying that for a little while. Welcome to the audience here in Carson City, anyone who's joining us in Las Vegas, and then whoever is online today. We're excited to have you for this most anticipated presentation today. As we begin, a couple of housekeeping announcements. Please silence your electronic devices. As always, you probably don't want to be the one that has your favorite ringtone go off during the meeting. If you wish to testify, please make sure you turn your microphone on, clearly state and spell your name for the record and your affiliation. Turn your microphone off when you are done speaking. And there's Assemblymember Gray. Thank you for joining us today. Members of the public may provide testimony on a bill in person or by telephone. To do so, please call 888-475-4499. And then when prompted, provide the meeting ID, which is 884-5992-0652, and then press pound when prompted. Meeting agendas are available on Nellis, as is committee information. All of that can be accessed through the legislative website. Public comment today will be taken at the end of the meeting. Please note that we respect courtesy and respect in all of our interactions during our meeting, even if we may not agree with another person's perspective or point of view. Committee members will be using their laptops, so please don't take that as a sign of disrespect. They have many things that they're trying to monitor on their laptop. So today, our agenda is an overview of Medicaid and social services programs in Nevada. I'd like to welcome you to the table. We have Administrator Stacy Weeks with the Division of Healthcare Finance and Policy, and then Deputy Administrator Programs and Field Operations, Kelly Cantrell. Thank you for joining us. Following their presentation, we will have 2 bill hearings today. Ladies, you may begin when you're ready. Thank you so much.
Good afternoon, Madam Chair. Stacy Weeks for the record, Administrator Division of Healthcare Financing and Policy. I have with me here today Kelly Cantrell from the Division of Welfare Supportive Services. We're here to give you a quick overview of Medicaid and Welfare and Supportive Services and their programs. So hopefully we're going to keep it light, but also informative for everyone because it can be very complex. So we tried to keep it, though, in a high-level 101, if that's helpful. All right. Some of you may have already seen this slide. We use it quite often when we walk through our budget, but I wanted to make sure you guys have a sense of the size of the program in Nevada. Medicaid, as you know today, is a state and federal taxpayer-funded health insurance program that's available to low-income families. It covers a core set of benefits at no cost to the members, and it covers currently, our program covers 1 in 4 Nevadans and about 1 in 2 births in the state. We are the payer of last resort, so if someone does have employer coverage, but they are low income and their employer coverage doesn't cover it, and we do, they're able to bill us for that service. Medicaid makes up about a quarter of the state's insurance market when you look at the size of the folks covered and the payer mix. As you can see, the largest portion of that pie is our employer coverage market. I would just note that the individual, which is that orange market, and the orange slice there is the Silver State Health Insurance Exchange and our individual health insurance market where individuals purchase their own coverage without an employer. As you can see, our uninsured rate has gone down. It used to be closer to 10%. So this is data that came from the Division of Insurance and is currently at 8%. Nevada, we do get a 60-40 match, and in Nevada, our federal funding for Medicaid is the largest source of federal funds for healthcare in the state. One of the things that's really great about Medicaid is that we can really drive as a state some of the performance in the healthcare system. We can use our payment models to really drive better value and reward providers who are performing well in the system. This slide just gives you a snapshot of our operations at the Division of Healthcare Financing and Policy. We work with our federal partners at CMS to provide coverage of quality health care to eligible Nevadans. We develop payment policies, benefits, and rates. We reimburse providers. We manage the budget and all the Medicaid finances. We also screen and enroll all providers in the Medicaid program, and we work to ensure compliance with state and federal laws around this program. We also have district offices that deliver care coordination services to our fee-for-service population and certain waiver recipients. We also oversee our managed care plans that do deliver and provide coverage for part of our program, and we oversee those contracts. We also handle all appeals from providers and enrollees when it comes to coverage. When it comes to eligibility, that is our sister division, which Kelly is here with me today, at the Division of Welfare and Supportive Services. So often you'll hear some people think Medicare is Medicaid. It is not. As you know, they are two different programs, and we want just to kind of give you guys a high-level snapshot of what the differences are. So when you're thinking about, you get a constituent call about Medicare, you kind of understand what the call is about, who to call, which is unfortunately not me. I often get a call about Medicare, and I wish I could help, but all I can tell you is that it is all managed and administered at the federal level. So anything to do with Medicare, they need to call their insurance company and call the federal government. It is funded by federal government and funded by the premiums that recipients pay. It covers 65 and older and some younger individuals who have certain disabilities. And it does not typically pay for long-term care. I think one of the confusions that we often see is that people think Medicare, once they get on it, they're good to go, they grow older, and then all of a sudden they need home care, or they need assistance, or they need some skilled nursing services. Guess what? Medicare doesn't cover. And so individuals are faced to pay pretty high, high bills, or they have to figure out how do they lower their income, spend down, and get on Medicaid. That is a big challenge for our seniors, and we have a pretty significant size, a growing size, of dual eligibles in this state, which we consider our Medicare and Medicaid covered population. So, which is 11% of the enrollees. We have about 800,000 enrollees, generally speaking, give or take what day it is. Medicaid, on the other hand, is managed jointly by the state and federal government. It is funded by both entities. It does not have a consumer premium. It also covers low income regardless of age and people with disabilities. It does pay for long-term care services and more. A lot of the home and community-based services that we see today are paid for through Medicaid. And it, like I mentioned earlier, it is the payer of last resort. So who is covered by Medicaid in Nevada? It's low-income adults up to age 64, children up to age 21, also low-income pregnant women and newborns, most seniors 65 and older, people with disabilities, children in our foster care system, guardianship, adoptions, assistance, and youth in our juvenile justice population. And just note in the parentheses is an important piece of this, up to 90 days pre-release. This is new coverage that was recently mandated a couple years ago. It was the Consolidated Appropriations Act at the federal level that was passed in 2022. It finally added coverage for youth who are in our juvenile justice system, who are pre-release. We'll be covering them. Right now it's up to 30 days, but once we get our federal waiver approved, we are hoping to be able to cover these youth up to 90 days pre-release. So this table here just gives you a snapshot of who is considered low income and what are those low income thresholds. As you can see, we cover children under Medicaid funding and CHIP funding, which is our checkup program, all the way to 205% of poverty. Pregnant women is right now 185% of poverty. We are working to implement with DWIS up to 200% of poverty. There's just a couple extra federal processes we have to go through and system changes, but we are working on that, and it was funded last session. Parents, we cover up to 138%, as well as childless adults. I would just note those two there have to do with the expansion population. So if you ever hear there's, the Medicaid expansion, it really was getting at those adults, parents and childless adults who were under 138% of poverty. If we expanded up to 138% of federal poverty level, we were eligible as a state to get 90% FMAP under the Affordable Care Act. And the smaller bucket here, even if it's smaller, it's still one of our more costly buckets. It is our seniors and people with disabilities. And it's only 74% of the federal poverty level. This slide here, the goal of this slide is really kind of to show you, when you look at the populations, the size does not always equate to cost in our program. Some of our largest populations, which is our children and parents, as you can see, which is 52% of the program, really only make up about 25% of the cost. When we look at the size of our child welfare and waivers or home and community-based waiver programs and others, as you can see, they're small at 7%, but they make up 31% of the cost. So it's really important to understand that the enrollment size, while it's important to understand who's in the program, sometimes people think, well, if our program gets smaller, the costs go down. That's not always true. It often ends up looking more like our risk pool is more expensive, and it's harder when it comes to health insurance to really manage those costs. So how does someone enroll in Nevada Medicaid? This is what we work with our sister division on. It's really, we have certain eligibility screening tools and processes. There's Access Nevada, Nevada Health Linked. We also have what we call presumptive eligibility in the hospital setting and other providers for pregnant women. But the hospital setting can be for anyone who is presumed to be eligible. If someone fills out an abbreviated application, the hospital can send it over, enroll. DWIS will enroll that individual. It's like a temporary coverage, essentially, until they complete the application in 60 days. And it really allows to avoid that gap in coverage. Paths to Medicaid enrollment to actually enroll would be through Access Nevada, by mail or in person, and the DWIS, district offices. We are proposing in the governor's budget an additional option, which would be real-time enrollment and plan shopping. With the expansion of managed care, one of the things we really want to start providing most of our population, which will be about 85% of our enrollees, the ability to shop for their health plan and to compare benefits, compare providers, and be able to pick that plan and enroll immediately and know what their coverage is. So we're proposing that, and there's funding in the governor's budget to implement that program. Hopefully you can read this slide. I apologize. I tried my best to make it pretty, but this is as pretty as it gets. What does Medicaid cover? It covers a set of mandatory benefits. So when you think about federal law, when we say mandatory, that's Title 19 of the Social Security Act. And it really says every state that has Medicaid, if you're going to get federal funding, you have to cover these services at a minimum. Don't forget, when you look at this list, if you wonder why in the world isn't, for example, dental or home and community-based services on this list, or why are other certain things on and certain things off, it's important to remember that this list was originally created, most of it in 1965, and has rarely been amended over the years. So as we've learned and changed about healthcare and really thought more about getting away from institutional care, you'll notice our mandatory benefits still kind of reflect that institutional setting. So the optional benefits under federal law include those on the other side. We also have new state plan benefits around home and community-based services that we can add. So when you think about a state's program, that's kind of what you need to think about, is what options have they taken to add to that benefit set. So how is Nevada Medicaid delivered? So you're going to hear a couple things in this committee quite often. For those of you that are new, you'll hear me talk about fee-for-service versus managed care. That really is our delivery systems. There's two types. Fee-for-service is more like you've performed the widget or the service and we pay you the fee, right? It's pretty basic. We pay you directly. There's not much else to it. There's really no drive for quality, utilization control. Managed care is very different. We pay them based on the cost for the population and their ability to do case management, care coordination, to try to drive individuals into lower cost, more appropriate care settings. We pay them a capitation payment to manage the population. As you can see right now, our population is 75% in managed care. I said earlier 85 because as of January 1, 2026, we're expanding statewide for managed care. So that'll add in another 75,000 people who will now be in managed care. So when we do that, the only people left in fee-for-service will be our seniors, people with disabilities, our waiver populations, and our child welfare populations. And right now, managed care is primarily in our two largest counties, Washoe and Clark County. So how is Medicaid paid for? I mentioned this earlier. We get, when you think of it, it's easy. The way to put it is we give $4 and the feds give $6 back, right? Our share, this is what we call FMAP, our federal Medicaid assistance percentage. But basically, it's a formula that's in federal law, and I'm not going to try to even pretend to understand how it's calculated. I was asking our economist today. But basically, when our per capita income or our economy does better, our share goes up and the federal share goes down. Right now in federal law, there's a cap at 50%. So some states are at 50, but as you can see, we're currently at 59. During COVID, we were a little over 60, but plus we also got an enhanced FMAP during that time, which brought us up pretty high. I want to say it was like 64, 65. I don't want to speak out like incorrectly there, but it was much higher. So we have recently seen that go down overall for our population. But like I mentioned earlier, our expansion adults are still eligible for 90/10, and there are other things in our program that sometimes we can get higher FMAP. But together, that's what we use to pay providers. So I often get asked, why didn't Medicaid pay for it? So this is supposed to be a button box where you answer the question yes, right, to everything, and then you push the middle, and the FMAP means, you win, you get your federal payment. So is the individual enrolled? If it's yes, that means great, they're in Medicaid. Is it a Medicaid covered service? So often, like I mentioned earlier, if the state hasn't added it or it's not covered, we can't pay for it. Is it a Medicaid enrolled provider? This is key. Just because a provider has a license or they're in good standing with the state does not mean we can pay them unless they're actually enrolled with Medicaid as a provider. It's a federal requirement. We go through our own process to enroll providers. And is the service medically necessary? We do not really cover cosmetic treatment and services of that nature. It really needs to be medically necessary. If all those things are in place, we can get federal funding and we will use our state dollars and pay the provider. This is in case you ever need like a reference point. I just wanted you guys to have sort of the federal authorities and the state authorities that really govern our program. So the foundation of our program really is at Title 19 of the Social Security Act and the federal regulations. We also get lots of guidance. It's really sometimes hard to keep up with. Sometimes I get calls saying, did you see this latest letter? And I'm like, no. CMS is constantly sending us state Medicaid directors. Also, we get state health official letters and other guidance that takes those regulations and really gives the administration's flavor, I would say, to it, right? How they want to implement the law. So sometimes when we think we have a path forward or we know what we're doing, sometimes the guidance changes. So we are constantly monitoring that, and it is significant amount of work. On the other hand, here is our state law. So the state law really tailors the program to meet the unique needs of the state. So we have Chapter 422, which is the chapter that you guys in this, for our program would be under this committee. We also have what we call our Medicaid state plan, which is our contract with CMS about how we intend to run the program. CMS, if we are in violation of that Medicaid state plan, if we are doing something and using federal dollars that we do not have approval for, either through a state plan amendment or through federal waiver, we could be out of compliance and at risk of recoupment of federal dollars or penalties. We also have what we call our Medicaid Services Manual. We're looking at kind of revamping this. It really is supposed to be and function more like a benefits policy manual for providers about how to get paid and what the requirements are around payment. Our Medicaid Assistance Manual, this is more with DWIS, this is the Eligibility Policy Manual, and there's also our managed care contracts that govern our program. So you add in that layer too, around quality and the other federal and state requirements around that. And I promised I would keep it fun, so bear with me. So when we think of, I put this slide together when we were working with, presenting to staff about why is Medicaid so unique and what does it look like? I like to say it's a special flower. At the bottom there, everything comes from that foundation. If we are doing anything outside of the Title 19 foundation or Title 21 for CHIP or checkup program, we're in trouble, right? Everything should grow from that. Then from that is our STEM, right? Most states have a STEM. Most states look the same. This is really the mandate. So every state has a similar STEM. It's the flower that's different, right? So every program is a little different. The flower includes all of our benefits, all of our state choices that the state makes, how we implement the program that makes our program unique. So people who live in California have a very different program than Nevada. And the choices that the legislature gets to make are really what changes that flower, if you will, with me. Those optional elements include funding, rates, what you want to cover, what you don't want to cover. Anything you do in that element or waivers that we seek really changes how our program operates and functions. But again, everything has to still be permissible and grow out of that same pot, if you will. It has to be permissible under Title 19. Sorry, one last fun slide. So I often get asked, just get me a waiver, and I always joke to people, the waiver is like the Medicaid unicorn. Everyone wants a waiver, but no one knows what for. They just know it's going to get what they want. It's got to be magical. And I will admit, waivers have allowed us to do some really great things in Medicaid. But if you want a waiver, my advice always is, what do you want to waive, and what is your goal? You may not need a waiver. Really what a waiver is it's a section, there's different sections of Title 19 that say, hey, states, will allow you to waive some of our requirements, right? Statewide-ness, comparability, other things that we typically want to see in Medicaid if you meet certain goals. And then we have to do a pretty lengthy application, especially for our 1115 waivers, to really prove that we are promoting Medicaid goals, that we have a budget neutral or cost-effective program, not to us, but to the federal government. Another myth I often hear is waivers are free. And I'm like, no. Again, as that Medicaid unicorn comes back, it's not free. Unfortunately, nothing we do in Medicaid is free. I wish it was. But we have to show that it's budget neutral to not us, but to CMS. And that can be challenging. We often have to have special metrics, outcomes. We have to do an evaluation plan. And if it's not budget neutral, we have to pay the cost to CMS. So I bring this only to say, if you want to do a waiver, let's talk and think about what rules are we waiving? Why do we need it? I always try to say if we can do a state plan amendment, that is the best route, and it's easier and doesn't take as long. Waivers right now are taking anywhere from 18 to 36 months or longer. CMS has a backlog and I think probably a staffing challenge that's bigger than ours. We have gotten better in that space, or I don't think they have. But, we had a waiver take at least 2.5 years recently. So I just really, caution you, not to say that waivers are bad, but they're not the unicorns that we often make them out to be, if you will. Bear with me on some of my humor today. All right, this is a list of all of our waivers in Nevada. We have home and community-based service waivers, which really allows us to cover home and community-based services for certain populations to help them support them with community living. So that's our frail and elderly population, individuals with physical disabilities, individuals with intellectual developmental disabilities. We also recently, I say recently, but it's probably been a year now, we've got approval for our coverage of treatment in what we call institutions for mental disease. So you guys probably recall many, many years ago, there was a problem where people were being housed and institutionalized who had mental disease or serious mental illness. To kind of stop that and combat that, one of the things that federal law prohibited for a very long time until this waiver, they allowed waivers, was that we could not cover any services in the institution because they were trying to get away from that. It had to be 16 beds or less. Now with these waivers that recently started under the Obama administration, then continued under the next Trump administration, and we continue to see it, is that CMS is approving waivers of that requirement. So now we can cover, we just got substance use disorder treatment approved, so we are covering those services, and we just amended our waiver to add in serious mental illness coverage. We're also seeking coverage of housing supports, meal supports, and navigation services for individuals who are who have mental health challenges or who are homeless in our population. We also just recently got approved coverage, limited dental services just for adults with diabetes who are served by participating federally qualified health centers. We are still working to implement this waiver, and I would just note that in the governor's budget, we have a proposal to add adult dental. It would be a basic benefit package. Our hope is that this benefit would be available to all adults in our program. We currently cover dental for pregnant women and children. Children is a mandate, so we cannot cut that. Incarcerated population and coverage. Last session, Assemblyman Speaker Yeager had a bill for seeking federal authority to cover individuals in carceral settings in the prison system. And to seek coverage up to 90 days. California was the first state to get that waiver, so since then about over a dozen states have sought these waivers. We just submitted ours in December. We're very excited about it, and including not only adults, it would be covered, like I mentioned earlier, that juvenile justice population would be covered. So we are in the pending federal approval process, which sometimes can feel like a very long time. But I think that's it, Kelly, and I think it's yours. Thank you.
Good afternoon, Madam Chair and committee members. For the record, my name is Kelly Cantrell, and I am a Deputy Administrator with the Division of Welfare and Supportive Services. Currently, our programs serve over 900,000 Nevadans. And one of the things that our eligibility staff do each day is bear witness to the beauty and the tragedies of human existence. And so as I go through our programs today, I'm going to share some of those stories with you. The Supplemental Nutrition Assistance Program was formerly known as food stamps, and it just helps qualifying Nevadans buy food. Many of you know that for some Nevadans, after they pay rent and utilities and household expenses, there's often very little left over to buy nutritious food. Each month, over 500,000 Nevadans receive food stamp benefits, and over 40% of that are children. And there's a story that I can recall of a young woman who was residing in a homeless youth facility. And she came to us one day and she was crying. She was hungry. And the staff member who was serving her, you don't know what to do. And so she had 2 protein drinks on her desk. And she said, "Here." And she handed her the protein drinks. And as they went through the approval process and the application process, the little gal drank it. And she got through, and it held her until she could get her benefits the next day. SNAP, or food stamps, it is the largest program in the domestic hunger safety net. We also administer summer EBT, and what summer EBT does is it provides $120 per eligible child in benefits for the summer months when kids are not in school receiving that free and reduced breakfast and lunch. SNAP education assist Nevadans with making healthy food choices. It helps them learn how to stretch their dollar on a budget, and it also puts an emphasis on physical activity. The Temporary Assistance for Needy Families, or the TANF or CASH program, provides cash to families to help children stay in their homes, to stay in the homes of a family member, or to stay in the home of a fictive kin. So it's someone they know. It keeps them oftentimes from the foster care system. It reduces dependency on social service programs by promoting job preparation, work requirement activities, and each person has a personal responsibility plan that they comply with. TANF offers support services like assistance with transportation, clothing, and any work card that could be needed for employment. Medicaid, which I touch very lightly on, approximately 55% of all Medicaid recipients receive one of the other programs that DWSS provides. Customers can apply online, over the phone, in person at any of our 22 local offices, or through our targeted outreach partnerships program, which we'll talk about here in a slide or two. And 50% of those applications are approved at the first interaction. I had a great nephew. I am not going to get emotional here. I had a great nephew who was born last year with a condition called hypoplastic left heart syndrome. And what that means essentially is he was born with half a heart. And I'm going to tell you guys today, my family would not have been able to cover the cost of his care without Medicaid. All of us together probably wouldn't. He has had multiple surgeries in the first year of life and will continue to have them throughout the remainder of his life. And the eligibility worker that assisted my niece was able to give her that peace of mind of knowing that she could deal with all the other things, and the cost of his care was not one of them. So I believe in these programs. Okay, I'm going to get myself back together now. The Energy Assistance Program. So what the Energy Assistance Program does is it provides a supplement for qualifying Nevadans to go towards the cost of their home energy. And anyone who's ever spent a winter in the north or a summer in the south knows the burden that these bills can be on a budget. It's expensive, and so that little program goes a long way to help people pay those bills and get through that. The Child Care and Development Program helps families maintain quality, affordable health care or child care while allowing parents to work or attend school or vocational training, and it promotes and provides support, education, and resources to Nevada's child care community. The Child Care Quality Program financially assist providers in their professional development through trainings and education. It aims to elevate safety standards, create enriching environments that provide a strong foundation for children's growth and learning. Childcare licensing ensures the health and safety and well-being of children in licensed childcare facilities by conducting inspections to ensure compliance with state laws and regulations. And it offers ongoing technical support through monthly trainings to caregivers, investigates complaints, and provides education to consumers, consumer education to parents. Our child support program helps locate parents and establish paternity, but its overarching goal is to ensure that children receive financial and medical support from both parents. It also helps foster responsibility from both parents, and it emphasizes the importance of both parents being involved in the child's life. Our Targeted Outreach Partnership Program. So this program connects people to the services that our agency provides throughout the community. We recognize that it is not always easy and customers experience barriers to getting to our offices. And traditional points of entry, it just doesn't work for everyone. And so what we've done is mobilize and send our staff out into the community where you wouldn't normally find someone who does eligibility. And so members of that team, they take applications, they approve applications, and they can even issue EBT cards on the spot. They travel with something that we affectionately call Office in a Box. They have their laptop, the scanner, a printer. They have the VPN for security while they're working, and that allows them to be not only efficient but very productive as well. Top sites are categorized into 4 main sections. We have justice involved, medical facilities, social service facilities, and one-stop centers. So for example, what does that look like? So we are in courts, we're in state prisons, we are in city and local jails, tribal health clinics, hospitals, schools, behavioral health clinics, libraries, nonprofit organizations. With over 220 sites, you can imagine that we're quite around the community. And not only do we have those 220 sites, we have over 100 sites on the waiting list waiting for our staff to provide services to the people that go to those facilities. In addition to the over 220 community sites that we service, the top team attended over 190 community events in 2024, and at those events alone, we were able to serve over 6,000 customers in urban and rural areas, so that they didn't necessarily have to come to us. We went to a back-to-school night, and we were there with the parents, and they could apply and be approved on the spot, and it's just really helpful, I think, for our community. This team, because of their mobility, they also serve as our disaster response team because they can pick up their office and go, and they're all throughout the state. This population serves unhoused individuals in a way that allows them to have access to our benefits because oftentimes they don't have a phone or they don't have a computer, and it provides that critical link to the community, to our necessary services. Okay, so lastly, let's talk about workforce services that we do at the division. Workforce Services and Development is made up of 2 units within the division. We have the Workforce Development Unit and the Recovery Friendly Workplace Unit. WDU, or Workforce Development, partners with various programs, including the TANF program, to find available funding for non-degree credentialing programs so that we can provide additional pathways out of poverty for TANF and SNAP recipients. The Recovery Friendly program, I think, is an amazing program, and it leads people that are in recovery to employment opportunities by providing not only workforce development, but also connects them with recovery-friendly employers. And what that does, it allows them to balance their recovery with employment commitments. The TANF and the SNAP program both have employment and training programs. And these programs provide our participants with the skills necessary to obtain and maintain sustainable employment that reduces or, in many instances, eliminates the need entirely for them to be on public assistance. Both of these programs conduct assessment to determine someone's work readiness. They provide case management, and they offer a variety of opportunities such as on-the-job training, vocational training, job search training. It's hard sometimes. How do I go look for work, right? Some of our folks just don't know. And it improves the skills and administer support services necessary for them to engage in the programs and overcome the barriers that they face. And I have seen firsthand the benefits that these programs can provide. Right within my own agency, we have had and we currently have 2 of our high-level and highly skilled managers that started out as volunteers through the employment and training programs when they were young single mothers going through the TANF program. So both of Stacy and I, Administrator Weeks, are very passionate about what we do, and we're very happy to provide the services that we provide. And so with that, I will close and say that Administrator Weeks and I are happy to answer any questions that you might have.
Thank you very much for that very fun presentation and also very heartfelt, Deputy Administrator Cantrell. Thank you so much for sharing that story, very personal story with us. We appreciate your willingness to be vulnerable in our committee, as we are often very emotional here. So thank you. And also really enjoyed the flower pot and the stem. So, and my personal favorite, though, is the unicorn. I think that we have a bunch of wonderful unicorns here in Nevada that we're doing some amazing work, and you two are definitely among that unicorn group. So thank you for being here. We do have a number of questions. I think we're going to start. Assemblymember Edgeworth, do you have a question?
Thank you, Chair. And thank you for such a thorough but concise presentation of a super complex topic. I have 2 questions. Question, if permissible. My first question is, and I'm not a dentist, I'm just prefacing this, but my understanding was that Medicaid covered emergency dental procedures through Liberty Dental. So is the expansion you're talking about for diabetics and for the general population restorative services that are already available to pregnant and children? Is that what we're talking about?
Madam Chair, committee member Stacy Weeks for the record. No, it's broader than that. So yes, we do cover emergency, but that doesn't include like cleaning, screenings, diagnostic treatment. Last session, Senator Neal had a bill that was passed that included restorative coverage for adults. That was in our base. Unfortunately, CMS said we cannot approve this until you add in screenings, assessments, diagnostic, because then you're assuming that the individual is going to pay for the initial x-rays and all the things that they need to get the restorative. So our goal is to add these basic benefits now, so that way we will have the restorative coverage. We can get that approved.
Okay. Well, it's a place to start, isn't it? Yeah, that's good. Okay, my other question is regarding the program. How do we, I don't think that's widely known in the community. I do a lot of outreach. How do we get people engaged in that, in your participation in events if we needed to?
So I will say that we don't, Kelly Cantrell for the record, we don't advertise specifically for specific reasons. So when someone asks, let's say the health department, when they ask us to come, the idea is that we're there to service the individuals that go to that facility. And if we start advertising, we think that people would end up showing up who came specifically for our services, and we don't want to do that. We want to be able to serve the population that's there. However, we do, like I said, we do have a wait list, and I can, if you have information, anyone has information, it can be given to our division, and then we can put them on a wait list, determine their need, do an assessment, right? And we can determine if they need immediate service, what that looks like. But it isn't a program that we necessarily advertise for specific reasons.
So again, sorry, we would reach out directly to your office, or is there a website, or?
Kelly Cantrell for the record, you can reach out directly to my office.
Okay,
Yes.
wonderful. Thank you very much.
Thank you. Next, we have Assemblymember Nadeem.
Thank you, Madam Chair, and thank you so much for a wonderful, great presentation. It couldn't have been better. Thank you for the great work you all are doing. So my question is that I heard that you are doing to the homeless people, Medicaid, they have the Medicaid facility, and you're expanding it to giving them the housing facility also. So I want to know more about it. Can you elaborate how you will be providing them with the housing facility?
Stacy Weeks for the record, Madam Chair, through you too. So I think what you're asking about is the Campus for Hope. I just want to make sure I'm understanding the question. Is that correct?
Yes.
Okay. Stacy Weeks for the record. I'm not as involved in that, but my understanding is that there will be transitional housing there to help individuals who are homeless not only get transitional housing, but also connect them with resources so they can get out of homelessness. The other thing that I do know is that there will be some services available that will be reimbursable for Medicaid. So I know that there will be some housing supportive services and other mental health treatment, things like that on site, is my understanding.
Okay, thank you.
Thank you. Before I go to our next question, would you, first you're welcome to go direct to the member. You don't have to come through chair. Thank you so much for that. Would you talk a little bit about, on page 4, you talked about your key division operations. Would you talk about rates? How often do the rates get reviewed? How many rates are you reviewing? What does that process look like? Just to give the committee a better idea of what you undertake.
Madam Chair, committee member Stacy Weeks for the record. We have in federal and state law, there's a quadrennial rate review process. So every, 4 years we do a rate review right now. So we're always looking actually at our rates. We just did one on behavioral health rates. We look at regional rates and states that are similar to ours to see how do we compare. The issue is that we don't change the rate unless we have the enough funding. And typically that requires legislation and budget authority. I will say that the number of rates that I would say thousands, because every rate is kind of tied to a code and there are thousands of codes. So when we look at a provider type, we have to think about all their codes. So a good example of a rate increase that was really significant last session that has taken a very long time to implement because it's such a big lift for our system was physician rate increases. Imagine how many types of physicians there are. How many types of codes fall under those physicians? Thousands and thousands and thousands. So we've been working on it since session ended last year. But it is all retroactive. We're going to get through it, but it is a lot to process. And we typically, what we're funded, we typically use that to set the rate. If we are asked to help advise on a rate, we will provide information we will look at cost, and we will also look at regional approaches to rate setting, and also look at states that are like ours that we think are reasonable rates. But it is challenging to address every rate challenge.
Thank you for that clarification. Next question we have from Assemblymember Jackson.
Thank you, Chair. I know you mentioned the transition of populations going from fee-for-service to managed care organizations. Will those deemed disabled by the state still have the option to stay on fee-for-service?
Madam Chair, committee member Stacy Weeks for the record. No one who is considered covered under disability will be moving to managed care. They'll be fee-for-service at this time.
Thank you, Assemblymember Jackson. We're going to go now to Assemblymember Gray.
Thank you, Mr. Vice Chair. So I'm a little boggled. So we talked about Senator Neal's bill with restorative care for dental, and I think there's no question that dental care is paramount to overall health. I mean, it's directly tied to cardiac care. My question is this body last session passed SB 163 that forced Medicaid to pay for transition services, which seems a whole lot more involved than restorative care. My question, it revolves around the process. How were you able to get that through and to get Medicaid to pay for those services, and we couldn't do, something with, somebody's teeth?
Mr. Chair, committee member Stacy Weeks for the record. Can you help me when you say transition care, do you mind helping me elaborate on that for a second? Thank you.
Gender dysphoria.
Mr. Chair, committee member Stacy Weeks for the record. The issue is not the benefit in restorative coverage. The issue is that there's something called, it's under federal law. It has to do with the preventative and screening and treatment services. So, for example, all of those restorative services are not available to the individual for free because they would be forced to cover all the services that are required before they are able to, including the x-ray, the diagnostic procedure. And CMS said you cannot offer these benefits and not pay for the other services that are needed to provide restorative care. So that's why we're seeking the preventative package. So the CMS will not say that we're essentially creating a situation where a Medicaid recipient has to pay a charge to get access to that benefit. I hope that makes sense.
Thank you. And I meant to open up with, thank you guys for the jobs you guys do. And I don't mean to put you on the hot seat. I'm just wondering, so, I mean, it seems like with, when somebody is transitioning, there are a lot of other things that go through, like, getting, with the dental, the preventative care. I mean, so were all those issues laid out prior to going to Medicaid saying, hey, this is what we need to do? Or like I said, the process boggles my mind.
Mr. Chair, committee member Stacy Weeks for the record, all the services prior to transitional care are covered. So this is the difference here. And unfortunately, at the time, it wasn't something that we were aware of either until CMS came back with the federal statute and said, sorry, you have to cover the full range here or someone can't access this service without having to pay a hefty bill.
Thank you.
Thank you.
Mr. Chair, one more follow-on regarding SNAP.
Quickly, please. We have two more
Thank you.
hearings.
This one should be an easy one. So this is for you, Ms. Cantrell. With regards to SNAP, our society has an issue where we equate nutritious with healthy. Is there any movement going on to move SNAP towards people buying more healthy food as opposed to the processed and the sugary and all those things?
Kelly Cantrell for the record. There's always talk about that. We've heard fairly recently a movement to say you can't buy sugary drinks, right, with your benefits. And we have been waiting on the newest farm bill. And so we suspect that this year that will come forward and we'll probably have some changes. And so we'll wait and see what those are. But it is a subject that never, ever goes away or we never stop hearing about. But moving towards those things sometimes can be a little bit slower.
Thank you. Assemblymember Gray. Is anybody, any other member have any other questions? Seeing none, I want to thank you both again. I want to echo Chair Brown-May on your work and all of the hard effort you put into everything. Just so passionate, and I'm just so in awe of your commitment to our state. So thank you. All right. With that, we are going to move on to our bill hearing. So we have two bills today. And the first one is Assembly Bill 36, which is on behalf of the Division of Healthcare Financing and Policy of the Department of Health and Human Services. Welcome back. This is an act relating to Medicaid, revising provisions relating to certain hearing concerning actions taken against a provider of services under the state plan for Medicaid and providing other matters properly relating thereto. So I'm going to open the hearing, and Ms. Weeks, please come back and introduce yourself and start whenever you're ready.
Mr. Chair, committee member Stacy Weeks for the record. Thanks for having me back. I'm here to present Assembly Bill 36. This is a bill that we are bringing and requesting changes to statute to really align with our policy manual for provider hearings. We consulted with our Deputy Attorney General on our team on whether or not we needed this, and they do believe that we do need to ensure that in state law, we are clear about the amount of time that a provider has to seek an appeal. We've had situations where providers have waited years to seek an appeal, and that can be challenging, not only from a record standpoint at times, but also just from a budget standpoint. Our policy manual says 90 days. This would align with that 90 days. I would just also note, too, that providers come to us to appeal a variety of decisions. It's not only just payment. It could be a provider disenrollment in Medicaid, so they have a right to appeal. It's just ensuring that every party knows what the timeline is and that we're clear in state law. It also helps our Deputy Attorney General's office represent us better with the courts when we are in dealing with litigation and appeals. And with that, I'll stand for questions. Thank you.
Great. Thank you for that. Questions? All right. Seems like you did so well last presentation. They ran out. All right. So if you would want to step back, we're going to open testimony in support of Assembly Bill 36. We're going to go to Carson City. I don't see a stampede going in for Carson City, so we'll check in Las Vegas. Don't see anyone there either. We're going to check the phone line. AVH, do we have anyone in support of testimony for AB 36?
Chair, the public line is open and working. There are no callers at this time.
Great, thank you. We're gonna go now to opposition. If anyone would like to come and testify in opposition for Assembly Bill 36, please come up. All right, seeing none in Carson City, we go to Las Vegas. All right, going now to the phone, AVH, do we have anybody in the queue for opposition testimony?
Chair, the public line is open and working. There are still no callers at this time.
All right, thank you, AVH. We're going into neutral. Anyone want to testify neutral in Carson City? All right, we'll go to Las Vegas. Seeing none, I will go to AVH one more time.
Chair, the public line is open and working. There are no callers at this time.
Thank you. Administrator Weeks, would you like to make any closing remarks? Okay, that was nice and easy. Thank you for welcoming me to this role. It's just an easy one, right? Any harder bills, please wait until Chair Brown may come back. All right, thank you. I'm going to go ahead and close the hearing on AB 36. Thank you again for your presentation, and we're going to move on to the next bill, which is Assembly Bill 42. All right, we'll open the hearing on Assembly Bill 42. This measure is also on behalf of Division of Healthcare Financing and Policy of the Department of Health and Human Services. It is a provision governing the adoption of regulation for the administration of certain programs of public assistance. And we will have the same presenters. Oh, okay. You didn't go too far. All right. Welcome back. Go ahead and state your name for the record and begin whenever you're ready.
Mr. Chair, committee member Stacy Weeks for the record. I have here with me our Innovation Officer at the Division of Healthcare Financing and Policy, Ann Jensen. I would like to defer to her to present the bill. Thank you.
Good afternoon, Mr. Chair, committee. My name is Ann Jensen, and I'm the Innovation Officer at Nevada Medicaid, and I'm excited to present to you all Assembly Bill 42. The purpose of this bill is to streamline the administrative process of amending Nevada Medicaid policy. This would allow us at the division to expand healthcare benefits or make mandatory regulatory changes more quickly in compliance with state or federal law. Current law requires that the administrator give at least 30 days notice of the intended action to adopt, amend, or repeal regulations. This bill would allow the administrator to instead provide 3 days notice of the intent to adopt regulations if the regulation is a federal or state mandate or law, or if it results in the expansion of services and benefits. This bill would also allow for the retroactive application of adopted regulations if mandated by federal or state law. This will reduce the implementation timeline of our policy changes, which currently take between 3 to 6 months. This does not impact the ongoing stakeholder engagement efforts that we take for all policy changes, such as our public workshops. Ultimately, the provisions of this bill will ensure that at the division, we are operating in full compliance and with increased efficiency. And with that, I will stand for questions.
Thank you very much. Members, do we have any questions? All right, 2 in a row. Awesome. All right, if you would mind taking a step back, we will go into testimonies. All right, we will now go into support testimony of Assembly Bill 42. Again, each person has 2 minutes to provide testimony. I'm seeing lines out the door right now. If you would like to come up to testify in support in Carson City, please come on up. All right, we'll go to Las Vegas. And now we'll go to AVH.
Chair, the public line is open and working. There are no callers at this time.
Thank you very much. We'll go over to testimony in opposition of AB 42. We'll go ahead and go to Carson City first. Anybody in opposition? All right, tough crowd today. Anybody in Las Vegas? Okay, and we'll go against the AVH.
Chair, the public line is open and working. There are still no callers at this time.
All right, thank you very much, AVH. Going to the last but not least, neutral on AB 42. seeing anyone in Carson. We'll go to Vegas. And yep, looks like nobody's moving over there. We're going to AVH one more time for neutral testimony.
Chair, the public line is open and working. There are no callers at this time.
Great. Well, awesome. Would you like to do any closing statement?
Mr. Chair, committee member Stacy Weeks for the record. I just wanted to say that we appreciate your time today, and this bill we do think will help us improve our process and streamline it. Right now it's very lengthy and administratively burdensome, so our hope here is really to make things faster, especially when there's state and federal mandates. So thank you.
Thank you. All right, that concludes our bill hearing for today. We're going to go to the last item of business, which is public comment. So I will now open up the time for public comment. As a reminder, each person has 2 minutes to provide testimony. Public comments may be submitted to the committee up to 24 hours after the hearing. Is anyone in person in Carson City would like to give public comment today? All right. Anyone in Las Vegas? And we will go now to AVH.
Chair, the public line is open and working. There are no callers at this time.
Thank you very much, AVH. And before I close the meeting, is like any comment from any of the members? All right. Well, seeing and hearing none, this meeting is now adjourned.